Hi class, this is Dr. Heather Austin Robillard, and this lecture is going to be over co-occurring disorders. Eating disorders do not often come without consequences. So far in this class, we've learned about different health and physical consequences. Along with these physical health concerns, individuals with eating disorders also tend to have co-occurring mental health disorders. This lecture video will highlight the most prevalent and common co-occurring mental health diagnoses with eating disorders. First, let's define what a co-occurring diagnosis or disorder is. The definition is the presence of two or more disorders at the same time. For example, a substance use disorder and a major depressive disorder. Formerly known as a dual diagnosis or dual disorder, it is now termed co-occurring or comorbid disorder. Having two or more disorders impacts the conceptualization of treatment. So you can't just focus on the substance use disorder if you're not also treating the major depressive disorder. And unfortunately, individuals with two or more disorders often receive insufficient treatment. Research is contradictory in terms of which disorder develops first. So it's kind of the chicken or the egg debate on whether the substance use disorder developed the major depressive disorder or if the major depressive disorder contributed to the substance use disorder. And it might be both and. There might be people who develop substance use disorder because of their major depressive, and some people develop a major depressive disorder because of their substance use. Here are the most common co-occurring mental health diagnoses with eating disorders: depression, anxiety disorder, PTSD, substance use or alcohol use disorder, borderline personality disorder, and self-harm. There is some data here showing this chart on the rates of eating disorders with co-occurring mental illness. You can see that eating disorders with depression is 70%, eating disorders with an anxiety disorder is 63%. Eating disorder with obsessive compulsive disorder is at 41%. Eating disorder with social anxiety disorder is at 20%. Those with PTSD and eating disorder are about 13%. And those with a panic disorder and some kind of eating disorder are at 11%. Anxiety disorders are described as clinical significant feelings of unease, worry, and fear. These include symptoms of feeling on edge, restlessness, fearful, powerlessness, a sense of doom or danger, difficulty concentrating, irritability, sleep disturbances, and physical symptoms like muscle tension, sweating, and heart palpitations. There are several different types of anxiety disorders, including generalized anxiety disorder, panic disorder, social anxiety, different phobias, obsessive compulsive disorder, and post-traumatic stress disorder. Delavar, Kendler, Neal, in 2001 confirmed that generalized anxiety disorder and anorexia nervosa share genetic and environmental elements that may contribute to their high comorbidity or high co-occurrence. Eating disorder and anxiety is at a higher prevalence than what is found in the general population, with estimates of up to 2/3 of those with eating disorders struggle with anxiety. Anxiety in those with eating disorders typically precede the eating disorder. They remain at elevated levels even when in recovery from the eating disorder and may negatively impact treatment outcomes. Some of the causes include early childhood experiences that may relate to trauma, teasing, bullying, and avoidant behavior, and even starvation. Treating anxiety symptoms early in treatment relates to better treatment outcomes for their eating behaviors. Since obsessive compulsive disorder is also considered an anxiety disorder, you can see this as being common among eating disorders as well. Obsessive compulsive disorder, or OCD, is the uncontrollable, reoccurring thoughts, obsessions, and behaviors, or compulsions, that they feel the urge to repeat over and over. Obsessions are those repeated thoughts, urges, or mental images that cause anxiety. These can include fears of germ contaminations, unwanted or forbidden or taboo thoughts. Compulsions are the repetitive behavior that a person with OCD feels the urge to do in response to that obsessive thought. For example, excessive cleaning and hand washing. Now let's take a look at some of the prevalence rates for OCD and different eating disorders. The lifetime prevalence of OCD in the general population is about 2.6%. With anorexia nervosa, it is 10 to 62%. Bulimia nervosa is 0 to 43%. And the patients who actually seek out treatment for OCD, about 5 to 17% of them struggle with eating disorders. Researchers estimate that OCD most often precedes the eating disorder development, much like anxiety disorders, with some researchers ascertaining that eating disorder is a subtype of OCD, while others argue that the eating disorder may lead to the development of OCD symptoms. Some research on treatment has concluded that OCD has little impact on the treatment outcome, while others contradictorily find that OCD complicates the treatment process and results in poor treatment outcomes. One study found that more severe OCD symptoms at discharge was related to higher probability of relapse. Storber et al. In 1997 found that extreme compulsivity and daily routines predicted longer time to recovery from anorexia. Milos et al. In 2002 found that eating disorder patients with OCD had longer eating disorder duration, indicated that OCD may be an eating disorder sustaining factor. Three main findings from large study on inpatients with and without OCD is that eating disorder patients with OCD are more ill at admission. They have longer eating disorder duration, a lower BMI, and more prior eating disorder inpatient treatments. There's also a greater likelihood of personality disorders and same amount of improvement for treatment outcomes for OCD and non-OCD patients. There was also no difference at the post-1-year follow-up between the groups. PTSD is also another anxiety disorder that is often found among eating disorder patients. PTSD stands for post-traumatic stress disorder. It develops as a response to a traumatic experience or events that threaten an individual's sense of safety. Researchers estimate that individuals, particularly women with an eating disorder, have a high co-occurrence with PTSD. It can be anywhere from 4 to 52% of those with eating disorders meet the full criteria for PTSD. Childhood sexual abuse is the most commonly reported traumatic event for women. Other traumatic events include sexual assault, physical and emotional abuse, teasing and bullying, parental breakup, or loss of a family member. Traumatic experiences are most commonly reported by those with anorexia and bulimia nervosa. Another common mental health diagnosis that is co-occurring with eating disorders are alcohol and substance use disorders. Compared to 9% of the general population that have a substance use disorder, approximately 50% of individuals living with an eating disorder will have a substance use disorder, and 35% of those with a substance use disorder will have an eating disorder. Eating disorders have been found to precede the substance use disorder typically. Other than alcohol, the following substances were most commonly reported to be abused by those with eating disorders: sedatives, marijuana, and caffeine pills. Research has considered the types of eating disorders and the rates of substance use disorder. Bulimia and nervosa and binge eating disorder had a higher association with substance use disorders than anorexia nervosa. Bulimia nervosa's group had the highest rates of any ED group in study, which is consistent with what other research has said. Bulimia nervosa patients also tend to report higher depressive symptoms, impulsivity, borderline personality disorder traits, and self-defeating behaviors. This study also indicated that when patients engage in a binge purge behavior, either in bulimia nervosa or anorexia, there is a higher risk for substance use. Anorexia patients are the least likely to abuse substances, likely to do with their high levels of avoidance and display of obsessional behaviors, which might result in limiting consumption. Another common mental health diagnosis with different eating disorders is the borderline personality disorder, or BPD. Borderline personality disorder is unstable moods, behaviors, and relationships. The symptoms include difficulty regulating emotion and thoughts, impulsive and reckless behavior, unstable relationships with others, extreme reactions, difficulty controlling anger, distorted and unstable self-image, chronic feelings of emptiness, reoccurring non-suicidal self-injury, and suicidal behavior. Individuals with BPD tend to use escape and avoidance strategies as a way to cope with their undesired thoughts and emotions. BPD tends to be more prevalent in bulimia nervosa at 21% and binge eating disorder at 9%, with lower rates in anorexia nervosa at 3%. But with the binge and purge, and not the restrictive subtype, which suggests common characteristics like impulsivity and emotional instability. The prevalence for BPD in eating disorder individuals is anywhere from 6 to 11%. That is compared to the 2 to 4% of the general population. 58% of individuals with BPD have an eating disorder. Individuals with both BPD and eating disorders present with weight loss, bulimia, self-harm, emotional liability, and impulsive behaviors. They tend to be a difficult population with concerns to treatment outcome. In general, studies have found that eating disorder individuals, around 30%, have some form of personality disorder, while 6.2% have BPD and specifically. Individuals with BPD and eating disorders have shown to be associated with higher distortions of eating attitudes, a history of frequent hospitalization, non-suicidal self-injury, and suicidal behaviors in comparison with those who do not have BPD but have eating disorders. Another common disorder is self-harm or self-injury. The non-suicidal self-injury is the direct and deliberate damage of one's own body tissues without the conscious suicidal intent. This includes cutting, burning, embedding objects in the skin, or breaking bones. It is estimated that about 25% of non-suicidal self-injury individuals are living with an eating disorder. And some research even ranges from 12 to 72% of individuals. While this disorder is more frequently seen in women than in men, and in adult psychiatric patients than other populations, but some studies say it is just a difference in assessment and being aware of self-harm. For example, women typically are cutters, whereas men typically bruise or burn. Studies have found that individuals with eating disorder that engage in non-suicidal behaviors have a worse eating pathology, a worse general psychopathology state, and more dysfunctional personality traits. Non-suicidal self-injury and eating disorders are both associated with higher levels of negative affect and difficulties regulating emotion. These harmful behaviors may be engaged as a way to gain relief from difficult emotions. Individuals with eating disorder and NSSI also report more traumatic experiences and present more features related to BPD. The factors associated with NSSI and eating disorders are specific personality traits, negative childhood experiences, negative affectivity, high emotional reactivity, negative mood intolerance, anxiety sensitivity, social and cultural risk factors. Some studies have found that anorexia nervosa patients are more likely than other eating disorder patients to display self-harm behaviors, and that this may be in response to meet the need to control weight, their body dissatisfaction, and for self-punishment. Suicidality is also very common in individuals with eating disorder. There are higher attempts of suicide in bulimia nervosa compared to anorexia nervosa patients. There are, however, higher completed rates in anorexia nervosa patients with more lethal methods of an attempt. Suicidality has been found to not necessarily link directly to mood disorder, but to other comorbid disorders like substance use disorder, impulsive behaviors, panic disorder, PTSD, severe eating disorder symptoms, and purging behavior. Professionals should assess for suicide even when the patient does not meet the criteria for mood disorder. This concludes the lecture for co-occurring disorders and among eating disorders. As you know, it's very common for those who are struggling with an eating disorder to also struggle with some sort of mental health disorder. And in order to assess and treat those individuals with eating disorders, we need to make sure we're also concurrently treating their mental health disorders as well.